Hi, my name is Audrey Dion, and I am a nursing student in the perinatal specialty. Today I will be using the situated decision-making framework to work through the breastfeeding challenge of an infant with jaundice and a mom with flat nipples. The situated decision-making framework is a tool for supporting the clinical decision-making process and can be applied to help women overcome breastfeeding challenges. It involves knowledge, cues, judgment, decision-making, and evaluation of outcomes. Jaundice refers to the yellowing of the skin and the sclera, or whites of the eyes, caused by elevated bilirubin levels in the blood. It is also known as hyperbilirubinemia. Bilirubin is a byproduct of red blood cell breakdown, which is increased in the newborn as they transition from in utero, where they required more red blood cells. Bilirubin is conjugated by the liver and excreted into the intestines and passed out in meconium stool. In the newborn, the liver is immature, and therefore it may not be able to keep up with the conjugation of bilirubin, leading to increased levels. If the infant is not passing meconium, bilirubin will be reabsorbed from stool back into the blood, further contributing to jaundice. There are three types of jaundice: pathologic jaundice, breastfeeding jaundice, and breast milk jaundice. Pathologic jaundice occurs within the first 24 hours of birth and is caused by conditions that lead to increased red blood cell breakdown, such as blood incompatibility. This is not part of the normal pattern of jaundice and requires treatment with phototherapy. Physiologic jaundice is a normal increase in bilirubin of healthy infants due to increased red blood cell breakdown in the newborn. It peaks on day 2 to 3 and usually clears within 2 weeks. Breastfeeding jaundice is an extension of physiologic jaundice that occurs in breastfed babies due to infrequent and ineffective breastfeeding and a delay of passage of meconium. It is not caused by a problem with the breast milk itself, but rather the infant is not getting enough milk. This can be due to poor latch, ineffective milk transfer, infrequent feeding, or the mother's milk has not come in. Breast milk jaundice is late onset jaundice that persists after physiologic jaundice subsides, and it is seen in breastfed babies that are feeding well. It occurs after the 5th day, peaks between 1 to 2 weeks, and may last up to 3 months. The exact cause is unknown, but it is believed that substances in the breast milk are blocking the breakdown of bilirubin. Consequently, bilirubin is reabsorbed back into the bloodstream from the intestine. Breast milk jaundice is only seen after the 5th day because the substances in breast milk are only found in transitional and mature milk, but not in colostrum. Risk factors for infant jaundice include gestational age less than 38 weeks at birth, non-exclusive breastfeeding, a family history of jaundice, birth trauma, infant of a diabetic mother, and blood incompatibility. It is important to note that jaundice occurs in up to 60% of infants, but rarely do any severe complications arise. It is important that all newborns be assessed for the risk of severe jaundice prior to discharge and that all parents receive verbal and written information about the signs and symptoms of worsening jaundice. The signs and symptoms of jaundice include yellowing of the skin and sclera, which usually appears first in the face and then will move down the body to the chest, abdomen, arms, and legs, lethargy and excessive sleepiness, a high-pitched cry, poor weight gain or excess weight loss, poor output, and elevated transcutaneous or serum bilirubin levels. It is also important to observe the mother-infant dyads for cues of the cause of jaundice, such as poor latch and ineffective milk transfer, and infrequent breastfeeding. There are 3 key points to remember in the management of infant jaundice: no interruption to breastfeeding, frequent and exclusive breastfeeding, and effective latch and positioning. In the picture, we can see that this infant has a nice deep latch, with the mouth covering the entire areola and the lips flanged out. This is important for the infant to stimulate milk production and effectively transfer milk. Regardless if the infant has breast milk or breastfeeding jaundice, the management and treatment are very similar. Breastfeeding should occur at least 8 to 12 times every 24 hours. We want to increase the duration of breastfeeding. The infant should soften at least one of the breasts, and the mother should offer both breasts at each feeding. We want to improve the latch and positioning, and supplementation only when medically indicated. This may be done with expressed breast milk, which can help increase the caloric intake of the infant while increasing milk production. Phototherapy, though rarely necessary, may be indicated if bilirubin levels remain high despite optimal management. But remember that both breastfeeding and breast milk jaundice are normal physiological patterns of jaundice and rarely result in severe hyperbilirubinemia. There are many breastfeeding challenges that relate to variations in breast anatomy and physiology. I will discuss the common challenge of breastfeeding for a mother with flat nipples, or nipples that do not protrude. It is important for mothers to remember that flat nipples are not a contraindication to breastfeeding, and most women go on to breastfeed just fine. We are in a society where bottle feeding is the norm, and therefore women may believe that if their nipples do not protrude like the nipple of a bottle, that it will not work. But this is not the case. The resting nipple length is unimportant, as the infant suckles at the breast, not the nipple. It is more important that the areola and breast tissue beneath can pull out to form a teat. For effective breastfeeding, the infant must get a deep latch with the whole areola, not just the nipple. Therefore, having a flat nipple will not prevent an effective latch or breastfeeding. The 3 key points still apply to the breastfeeding challenge of a mother with flat nipples. They should not interrupt breastfeeding. It will be beneficial to feed the infant more frequently, as this can help the nipples protrude more over time. And the most important point to remember is the importance of a deep latch with the entire areola in the infant's mouth. She may also need more help with positioning. The football hold, as is seen in this picture, can be a very useful position as it offers a mother a good view of the infant's latch. If the mother is concerned in having difficulties, referral to a lactation consultant can be beneficial. Some other useful tips to help mothers with flat nipples breastfeed are to roll the nipples between the thumb and index finger, put a cold cloth on the nipple for a few minutes, massage the breast, express some breast milk, and the use of a syringe to pull out the nipple. These are all strategies to help the nipple protrude more before breastfeeding and make latching easier for the infant. Nipple shields can also help the infant latch. However, they should only be used temporarily. To evaluate the effectiveness of management of both infant jaundice and flat nipples, it is important to assess the mother-infant dyad for signs of a good latch, effective transfer, and adequate milk intake. The infant has a deep latch around the areola, cheeks are full and rounded, and lips flanged out. Infant sucking and swallowing is audible. Mother feels a tug, but it does not hurt. Infant is feeding 8 to 12 times every 24 hours and softening at least one breast every feeding. The infant releases the breast on their own and appears satisfied for 1 to 2 hours after feeding, and the infant has adequate output and weight gain for age. Infant jaundice can be related to a mother with flat nipples if effective breastfeeding is not established. It is important to remember the 3 key points when overcoming both of these breastfeeding challenges. No interruption to breastfeeding, frequent and exclusive breastfeeding, and effective latch and positioning. Thank you for listening to this presentation. You are now equipped to use the situated decision-making framework to help the mother-infant dyad with the breastfeeding challenge of infant jaundice and flat nipples Here are a few questions to test your knowledge.